Hello, everybody. I'm Dr. Vivian Lin. I'm one of the obstetrician gynecologists at St. Jude Heritage Medical Group. I'm very excited. It's an honor to be able to be here and talk to everyone about a topic that's very close to my heart. That's a topic that affects all the women, whether we are in our reproductive years or even into our menopause years. It's a topic that could scare a lot of people because we have a lot of fear about, and we hear a lot of myths about being pregnant and what it could do to our pelvic floor, and what kind of damage having a baby vaginally could create for our pelvic floor. And so it creates a lot of fear for women. And so my goal today is to be able to share some information about pregnancy and its effect on the pelvic floor, to be able to dispel some myth and clarify some questions, because I think, I'm biased, I'm an obstetrician. Pregnancy is an amazing journey, and I hope everyone can be excited about this journey. And it's just a privilege to be able to carry a baby and have a baby of a family of our own. So I hope this can help educate people and make you feel better about it. What is pelvic floor? So the pelvic floors consist of muscles, the fascia, like the connective tissue, and nerves. That's what our pelvic floor is consist of. Pelvic floor consists of big muscles that extend from the tailbone all the way to the pubic bone. The big muscle groups are levator ani muscles. You can see it in the picture, and the coccygeus muscles. And these muscles go in different directions. Some are linear, some are tubular, and they work together like a hammock to be able to support our pelvic organs. So our pelvic organs are like the bladder, the uterus, the vagina, the rectum. So it helps support those pelvic floor organs so that they don't fall and they don't drop. So the muscles, some are linear, like I mentioned, some are tubular. So so like the circular muscles will wrap around the vagina, it goes around the anus. So they stretch to be able to allow us to have a baby vaginally. And they stretch so that we can be able to have bowel movement. And they close up so that we don't leak urine when we sneeze and cough and exercise. They're very important in vaginal health and intercourse, and also very important in pregnancy. The nerves that innervate the pelvic floor come from the lower part of your spine, the sacrum part of your spine, S level 2, 3, and 4. And so they come out and merge together and become a large nerve called the pudendal nerves. So the pudendal nerves is actually what innervates the sphincter muscles around the anus, and also other pelvic floor muscles. So as you can imagine, if you have damage to these nerves, these pelvic floor muscles, then you can have pelvic floor dysfunction, can have issues, with your having pelvic pressure or having incontinence. Weakening of the pelvic floor muscles can also cause back pain. And that's why a lot of pregnant women complain of symptoms of back pain during pregnancy, sometimes even after the pregnancy is done. And so a lot of times the back pain is not from the epidural, it's just from weakening of our abdominal muscles and our pelvic floor muscles. So those are the pictures that show you what the different types of pelvic floor muscles. So what happens to the pelvic floor muscles during pregnancy? So these muscles, these hammock muscles, work really, really hard to support a growing gravid uterus. At term, when you are close to delivery, the uterus can easily weigh 7 to 10 pounds. Just, the blood volume, the muscle mass, the amniotic fluid and whatnot can weigh that much. And so that creates a tremendous amount of pressure on your pelvic girdle and your pelvic floor. That's why a lot of women at the end, they feel so much pressure. They feel like the baby's going to fall out. It's because the pelvic floor is so strained and stretched and it's very heavy. And there are some hormone changes during pregnancy that can affect the pelvic floor. So your body creates hormones that can relax cause different property changes to the collagen and elastic tissue. So allow the muscles and the fiber to stretch. It can stretch up to like 3 to 4 times of the original size if it need to be, to have a baby vaginally. And so that combined with genetic susceptibility, because everybody's built differently biologically, so everyone's degree of how much your pelvic floor can stretch is different. So the hormone changes in the pelvic floor, I'm sorry, the hormone changes and the genetic susceptibility determines, ultimately how much injury, if there's going to be any injury to your pelvic floor. So as you begin to go into labor, baby begin to drop down into your pelvis, engage into pelvis, begin to come down into your pelvis. You can create tremendous amount of pressure and strain on your pelvic floor and the nerves and the fascia. So as you go through the course of labor, the widest part of the baby's head as it comes through the pelvic floor, the muscles, and the comes through out of the vagina is called crowning of the head. We think that's when it's most amount of pressure created on your pelvic floor muscles. And this is when injury and tearing can happen because that's the widest part of the baby's head coming through the vaginal canal. So some may ask, why not just do episiotomy? Because they think episiotomy can help prevent pelvic floor dysfunction, can help prevent tearing, but it's actually not been proven to help. So episiotomy was recommended 100 years ago, a long time ago, as a strategy to prevent perineal laceration or pelvic floor dysfunction. However, the literature actually has not been proven to show that. So that's why currently it's not a recommended routine procedure to perform episiotomy. So episiotomy is when you take scissors and actually cut the perineum into the muscles to allow more room for the baby's head to crown and come out. And patients sometimes will ask me most people ask me, don't do episiotomy. Some people ask me to please do episiotomy because I hear, if you do episiotomy, you can control the tears, it won't tear as much. So I will explain to patients that episiotomy has not been proven to prevent pelvic floor dysfunction. In fact, I prefer the tissue to stretch because when it stretches, it tears less versus if you make an intentional cut to the perineum. Just like if you have a piece of like a little bit of rib in your clothes, sometimes the rib will extend. So your laceration actually can get worse if you do an unnecessary episiotomy. Now there's circumstances where episiotomy is indicated and we will communicate with our patients and let them know this is why we need to do the episiotomy and get their consent to do the episiotomy to expedite the delivery in a more urgent situation, but it's not a routine practice. As a baby's head start crown, these are the lacerations that potentially can occur to one's pelvic floor. Okay, so you can have the perineal tear is to classify into 4 different degrees. You can have first degree that is just tear through the vaginal mucosa. The second degree is when it tears through the vaginal mucosa into the muscle of the vagina. Third degree is when it tears through the vessel of the vagina all the way through the muscle of the anus, the anal sphincter muscles. Fourth degree is the worst, the most severe degree of perineal laceration. That's when it tears from the vaginal mucosa all the way down to the anal mucosa. And so proper repair is the key. You can't control if someone's going to tear and how much tear they have, but proper repair is really important, really essential to put the muscles back together, all the layers back together so they are reapproximated well, so they have the best chance at healing. If you repair well, then you'll recover well 6 weeks later. The risk factors for birthing trauma. So as you can imagine, large baby is a very important risk factor. Studies have shown that if you have babies that are bigger than 8.5 pounds, 9 pounds, more likely to have pelvic floor injury and injury to the anal sphincter muscles and the vaginal muscles. Makes sense because the baby's large, it needs more room, more stretching, so therefore more tears. Nulliparity, meaning this is your first baby. That also makes sense because your pelvis has never been stretched before. This is the first time. And so it will cause some tear. It's very common to have a first, second degree tear. The first time having a baby, it may not happen with subsequent deliveries because it's been stretched and tissue is more pliable. And so usually subsequent pregnancies and deliveries, you have less tear. But the first one, usually, I always tell people, creates a path. First baby is the hardest, but after the first one, your future pregnancy should be a lot easier and labor does go faster. Operative delivery, such as using forceps to assist the delivery. Forceps are like big clamps that you can, clamp around the baby's head to assist a very difficult delivery. When someone's been pushing for a long time or baby's not positioned correctly, you're trying to correct the position and help deliver the baby's head. So as you can imagine, that creates more pressure and can cause more injury to the muscles and the fibers and the nerves. Sometimes the vaginal mucosa can get caught in the forceps, and sometimes the muscles can get caught in the forceps and cause more injury too. It is really difficult to say whether or not forceps itself causes birthing trauma or difficult deliveries that require forceps assistance actually cause birthing trauma. But in general, we know people can have more birthing traumas with forceps, so we try not to, or we really discourage unless it's absolutely necessary. Prolonged second stage of labor. Second stage of labor is from the time the woman is completely dilated to the time that they deliver the baby. So when it's prolonged, that means the head has been sitting in the vagina for a long time. Sometimes it's necessary because we, let the labor do the work, let the contractions bring the baby's head down, and the baby's head is soft, it will mold, it will overlap. So some babies come out with a cone head trying to accommodate, the shape of the pelvis to be able to come out. Sometimes so it's necessary, but prolonged second stage of labor can cause more birthing trauma because the nerves and the fascia has been stretched for a prolonged period of time, so they can get injured, they can get damaged and weakened. So what happens after delivery? So because the pelvic floor has been injured, separation of the endopelvic fascia and its lateral attachment can cause urethral or bladder hypermobility. So that bladder and the bladder neck, the urethra, is not very well supported. So when you sneeze and cough and exercise, it bounces and it moves, and so the urine can come out. It can cause incontinence. C-section does lower the percentage of bladder or stress incontinence. And other risk factors like obesity can increase the risk. Previous vaginal deliveries can increase the risk, forceps delivery, and also genetic susceptibility. What's your tissue's initial strength? How much is your body biologically designed to stretch? Can also determine if someone will end up with stress incontinence. Stress incontinence, though, is very common. It's very common. It actually can start in the second trimester of pregnancy before you even deliver. It can peak in the third trimester of pregnancy. It can last even after you have the baby, but majority of the people, 70, 80% of people, stress incontinence, if it does occur, it will resolve, within the first 12 months of postpartum period. Sometimes, I would say about 20% or so can last past 12 months. That's when pelvic floor physical therapy comes in very useful, because with pelvic floor physical therapy, you can help strengthen your pelvic floor muscles, and that can help improve stress incontinence and improve your quality of life. Damage to the anal sphincter, especially if you have a third and fourth degree tear, like we talked about earlier, can cause anal incontinence. Sometimes the pelvic floor and the fascia is so relaxed, you actually get pelvic organ prolapse, and that is a more severe form of pelvic floor dysfunction or injury. That's when the tissue is so relaxed after vaginal delivery or multiple vaginal deliveries that it just doesn't hold. The hammock is not as strong anymore. They are defects in the hammock. And so the bladder can drop. It can drop into the anterior part of the vagina, cause a bulge there. It's called a cystocele. The rectum can get weakened and push forward into the vagina, so your vagina can have a bulge there, and that's called a rectocele. Sometimes the uterus can drop. It's called a uterine prolapse. So that is more severe form of pelvic floor dysfunction. It's because the connective tissues and the pelvic floor muscles are damaged and too relaxed. So some may ask me, why don't I just do a C-section for delivery to prevent any pelvic floor muscles? So my answer to patient is always that it is better to have a vaginal delivery. Our body is designed, is built to have a vaginal delivery. They are risk with a C-section. It's not without any risk. So the risk of C-sections start with any surgical, just like any surgical procedure, bleeding, infection, possibly injury to your abdominal organs, possibly requiring blood transfusion if you lose a lot of blood, potentially can increase your future risk for your future pregnancies, because it can cause abnormal position your placenta, can increase your risk of hemorrhage with your subsequent pregnancy. After a C-section, you are more likely to be non-mobile, more sedentary for a while, so that increases your risk of blood clot in your legs called deep venous thrombosis. That clot can travel to your lungs and cause pulmonary embolism. You can have pneumonia from not breathing well, not ambulating. The C-section goes through layers of your abdominal muscles. And so we do put all the layers back to its anatomical position so you can heal properly, but it takes 6 weeks to heal. And so C-section can weaken layers of your pelvic, of your abdominal muscles, and can in turn increase risk for more back pain and more discomfort in the back because you don't have a strong core. So C-section is not without any risk. Their studies have shown that it takes 7 to 12 prophylactic, preventative C-section to prevent one pelvic floor dysfunction. And so it is better to allow your body to do what it's designed to do, to try to have a trial labor vaginally, and only do C-section if it's clinically indicated. Okay. And not to mention C-section has slower recovery because it's more painful. You need to take more medications and sometimes even narcotics. So that's my presentation today. I hope by sharing my knowledge and information with everyone, I hope I can make you feel better about being more educated about pelvic floor and in its relation to pregnancy. We have great pelvic floor physical therapy programs, so don't hesitate to ask your gynecologist, your obstetrician about getting started early, whether it's in pregnancy or after delivering the postpartum period, to help strengthen your pelvic floor muscles, especially if you're starting to feel symptoms of incontinence during pregnancy or after delivery. So early intervention is also very important. And so thank you for the opportunity to talk to you. And I hope to see you soon. Take care.